We're going to see nephrolitiasis. Nephrolitiasis presents as flank pain, extremely flank pain, sometimes with radiation to the groin. Rarely, but in women can radiate also to the clavicle, and is extremely painful. The patient cannot find a comfortable position. This as opposed to, for example, peritonitis, in which the patient is all like contracted. So here the patient is constantly moving. The examination that we need to perform, or the let's say the differential diagnosis, would be when we have a extremely flank pain. We should consider, for example, pyelonephritis and the kidney stones, the nephrolitiasis. And sometimes we think that the flank pain due to kidney lesion, like a stone in the kidney or pyelonephritis, is the most painful pain that the human can experience. The first step when we suspect that the patient has the kidney stone is analgesic medications, so analgesia and IV hydration. First the analgesia, then the hydration, and then the removal of the stone. Now the management of the stone depends on the size of the stone. First, if it is less than 5 millimeters, usually it passes along with just fluid intake. If it is greater than 5 millimeters, let's say between 7 and 10 millimeters, we give ureter's dilator agents in order to dilate the ureter and allowing the stone to pass. These are, for example, tamsulosin, that is a alpha-1 selective blocker, adrenergic blocker, or nifedipine. So, if it is larger than this, let's say 20 millimeters or so, but certainly less than 1 centimeter, we can do lithotripsy percutaneously or transuretral. And if it is very large, then with surgical removal due to, well, in this case we don't do lithotripsy because these fragments the stone, but if the stone is very big, the fragments are going to be big and can get stuck in the ureter. If the stone is actually a staghorn that is taking the form of the kidney, let's say this is the kidney, this is the ureter, here is the renal pelvis, all this. The staghorn can have something like this shape, and this is not only a stone. This certainly needs to be surgically removed. Now, the diagnosis of nephrolitiasis would be with a CT scan of the abdomen, because mainly almost all the stones can be seen here, well, at least more than in the chest X-ray. Remember, in the chest X-ray, sometimes we can only see the well, it depends on what's composed the stone. We have calcium stones, uric acid stones, magnesium phosphate ammonia stones, and cystine stones. So in the chest X-ray, calcium stones and ammonia phosphate magnesium are radiopaque, so that means that we can see them radiopaque. Uric acid are radiolucent, and cystine are a little bit more radiopaque than the uric acid, but not completely radiopaque. But let's say that is faintly radiopaque. Now, in the CT scan, certainly the calcium and the phosphatemia ammonia are radiopaque. radiopaque. The uric acid is a little more visible than in the chest X-ray, and cystine is almost also radiopaque. Anyway, now we do the diagnosis with the CT scan. In the chest, in the X-ray of the abdomen, we can only visualize the stones that are in the kidney, but not in the ureter, because in the ultrasound also we can see the stones that are in the kidney, but not in the ureter, because the transducer for the ultrasound is anterior and the ureter passes posterior, so we cannot visualize them. The sonogram or the ultrasound is used more to monitorize the sequels of the nephrolitiasis, but not the diagnosis of the nephrolitiasis. Sometimes we need to put a stent placement. This is only to relieve obstruction, because sometimes the stone is producing obstruction that leads to hydronephrosis. So the stent placement is only if there is obstruction. Now the obstruction do not cause increase in creatinine unless the obstruction be bilateral. If it's bilateral, we will see increase in creatinine. If not, we would not see the increase in creatinine. Now the specific gravity of these individuals usually will be greater than 1.015, and this means that the urine is very concentrated. The risk factors are age, like middle age, 40 years of age, because then becomes decreasing the incidence. For example, at 60 years of age is less commonly than in 40 years of age. And certainly the patient needs to take a lot of fluid for treating this stone and for preventing to have another episode, or to prevent to have it the first episode. Now, the risk factors depend for each one of the stones. For calcium, the most common cause is to have an increase in the urine calcium, and the most common cause is a normal hypocalcemia, hypercalciuria. Also, if there is a decrease in citrate intake, or increase in protein, or decreased potassium, this is also associated with increased risk of calcium stones. Now, the calcium stones can be calcium oxalate or calcium phosphate. The most common are calcium oxalate, and this is linked, for example, to Crohn's disease. In Crohn's disease, there is malabsorption because of all the fat. The fat binds to calcium, and so the calcium can no longer bind to the oxalate in the gut, and so the oxalate is reabsorbed and go then to the kidney and is filtrated, and then the oxalate binds to the calcium and is precipitated as a calcium oxalate stone. And so an increase in oxalate would lead to calcium oxalate stones. Here, the treatment is the same for all these stones. Well, no, it depends on if one are staghorn, but the issue is that here, for preventing specifically this, we can give hydrochlorothiazide, that is a thiazide, and this increases the calcium in the blood at the expense of decreasing the calcium in the urine. So this is the long-term treatment if the patient has a calcium oxalate stone. The treatment with just reducing calcium is not appropriate, because if we reduce the calcium intake of the patient, is, for example, if the patient has Crohn's disease, that the calcium is reduced because the calcium is binding to the fat, and so the oxalate will be reabsorbed, and so the patient will have calcium oxalate stones. So we don't need to reduce the calcium intake, and also it's associated with other side effects. So for long-term treatment is hydrochlorothiazide. Next, the things that reduces the risk are, for example, orange juice, caffeine, and things like that. But just with taking a lot of water would be fine. But like taking 2 liters of water, and don't to be in the other extreme, in which the patient can have primary polydipsia. Well, anyway, ammonium phosphate magnesium stones. This looks like a, they say like lead lag. I see them more like as a triangular prism. I see these stones something like this. Oops. I cannot draw it very well. Something like this. But in the kidney, the stone would be as a stag horn. So this needs surgical removal, and the long-term treatment is antibiotics. These stones are seen more commonly in alkaline urine, and the infectious agents are Staphylococci, Pseudomonas, Klebsiella, and Proteus. Proteus is the most common organism, and Proteus. This is because they have the urease enzyme. The urease enzyme converts the urea to a alkaline medium. So here the treatment is to acidify the urine. Acidify the urine. For cystine stones, this also produces a stag horn, but this is seen with a genetic disease that promotes decreased reabsorption of ornithine, a precursor in the urea cycle, lysine, arginine. These are two amino